I would like to take a moment to thank everyone for joining us this evening for a conference on global pediatric surgery given by Dr. Sherif Emil. It is really an honor for me to have collaborated with CGSTA, McGill University, and Dr. Emil to organize this talk, and without your participation and interest, this would not have been possible. I would also like to welcome all the international students that are present tonight. I know that for some of you, it's quite late or quite early in the morning, so really thank you for being here. We have people from around the world, from Harvard University, Johns Hopkins University, Spain, Paris, London, Sydney, China, Brazil, Romania, Bulgaria, Germany, Italy, Nigeria, Tunisia, Egypt, Pakistan, Philippines, and many more. And of course, I would like to thank all the Canadians and McGillians who are present tonight. So please note that the conference is recorded. So if you do not wish to be in the recording, we invite you to close your camera. So the agenda for tonight is the following. The talk of Dr. Emil Sherif will last for about 45 minutes and will be followed by a question period. So please make sure that your mic is off during the presentation. You're welcome to keep your camera on if you wish so. And we will ask you to wait until the end of the presentation to ask your questions. So before we start, I would like to acknowledge that McGill University is on land which has long served as a site of meeting and exchange among Indigenous people. We acknowledge and thank the diverse Indigenous people whose presence marks this territory on which people of the world now gather. So you might be wondering, what is CGSTA? So CGSTA stands for the Canadian Global Surgery Trainees Alliance and is a student-led national global surgery organization in Canada that aims to develop strong networks for collaboration, education, and advocacy on the theme of global surgery. So without further delay, I would like to introduce our speaker, Dr. Sherif Emil, who is the Director of the Division of Pediatric General and Thoracic Surgery at the Montreal Children's Hospital.
Thank you so much, Cecilia. It's really wonderful to have you from all over, but you thanked so many people, and I have to thank you because you did a lot of work, and I just don't know how you got people from all over the world here tonight. That's really quite amazing. So congratulations to you and your team at McGill and throughout the country for putting this on. I'm really, really excited to join you all today. I speak to many different audiences, but I'm honestly and genuinely most excited when I speak to students because it's very simple. You all are really the future of our profession. And I think the more I speak to students, the more I feel like our future is in good hands. And the more I feel like maybe it's time for me to slow down and wear off. So it's a really good feeling that the future holds a lot of great things. Let me share my presentation. I think you just need to allow me again, Cecilia, to share because I can't bring my presentation up. Okay, thank you. Yeah, it's good. All right, very good. So Cecilia invited me to speak, and she actually chose the title, The Life of a Global Pediatric Surgeon. And I think she sort of meant for me to talk about what my daily routine is like, how do I integrate global surgery maybe into my professional life. And I think I will do some of that, but it actually gave me a chance to reflect these last couple of weeks and sort of think about how did I get involved in this and what triggered my interest in this whole area of kind of working outside our borders, working beyond our comfort zone, if you will. And so it really has been a time of reflection. I can tell you that I have not given this talk before. So you have to let me know if you like it. I'll probably give it again. And if you don't, I probably will never give it again. So you have to give me your honest opinion afterwards. But I really wanted to reflect and kind of take a little journey. And this is why the subtitle, I decided to call it Lessons from the Past, Visions for the Future. And it really is a lot about my perspectives. This is not a big academic talk. I'm not going to show you a lot of statistics. It really is about a very real world perspective from years and years of working in many different settings. So just because we have a lot of people from around the world, I'm coming to you from the McGill University Health Center in Montreal. The yellow building you see here is one of the 2 children's hospitals on our campus. That's the Montreal Children's Hospital. The blue building is the Shriners Hospital. And we're very lucky because we have 2 children's hospitals on a huge medical center campus with lots of resources, and really almost the exact opposite of so many of the settings that I will be speaking to you about today. And I'm actually right now sitting on the 4th floor in a very tiny office in this yellow building. So just as a disclosure, I am the pediatric surgery specialty consultant for Mercy Ships. It is a volunteer unpaid position, but I will be speaking a bit about Mercy Ships today. And so I need to declare that I do have an administrative position with the organization. So I didn't want to list a whole bunch of objectives. I really want to share my reflections on my journey of almost 50 years. And I thought that a really good construct, a really good way to look at global surgery is this sort of kind of infinite circle here. And the circle has to do with need, access, and quality. And they're all interrelated, as you can see. One does not really supersede the other. But a big part of it is advocacy and education. And I think that's maybe one of the things I really want to stress tonight is that when we talk about global surgery, we often think about capacity building. We think about, creating resources, creating organizations, creating buildings, volunteering, etc. But a huge part of it is about education, and I hope to be able to share where that fits into my journey over the next few minutes. So, you're all obviously have a super strong interest in global surgery. I'm not going to show you a lot of statistics because you would have seen a lot of it before, but I just want to show you one statistic that applies to our specialty. The number of practicing pediatric surgeons in the 5 largest US metropolitan areas, which have about 3.3 million children, is actually the same as the number of practicing pediatric surgeons in all of sub-Saharan Africa, which has about 500 million children. So that starts to give you an idea of the amazing gulf that exists between our worlds when it comes to pediatric surgical expertise. And we know that that disparity translates into mortality. We participated in a study with a number of centers from around the world, both in high-income countries, low-income countries, and middle-income countries. And you can see that for many of the what we call the index pediatric surgical conditions, the conditions that really define what a pediatric surgeon does, like Hirschsprung disease or intralectal malformations, atresias, etc., you can see what the survival is like in high-income countries and what the survival is like in middle-income countries and low-income countries. And really, pediatric surgery is a bellwether. It is a manifestation of the resources that exist within a healthcare system because they directly correlate with how patients do. And it is really sobering to see the differences that exist in these countries. Now, all of what we do is about patients, right? So we can see all these numbers, and these numbers can be intimidating, but what does it mean in people's lives? So I just want to run this 3-minute, very recent documentary that will give you an idea of what this translates into.
Ce n'était pas facile quand j'ai accouché. Ils ont fait une césarienne parce que tantôt, en tout cas, ce dernier échographie que j'ai fait, on a vu que c'est sa tête. C'est quand on m'a opéré, on a vu que c'était pas la tête.
Teratoma is the Greek word for monster. And when you see these tumors, you totally understand why they're called that. They're massive.
J'ai assisté à la naissance de ma mère. On a opéré ma petite sœur. On m'a présenté l'enfant. J'ai vu que l'enfant, les médecins eux-mêmes ne savaient pas quoi faire.
irony of these tumors is that the overwhelming majority, over 90%, are benign. They're not cancers, they're not malignant tumors. But when not treated, they do become malignant and they do kill the child.
Moi, quand il restait, je réfléchissais comment l'enfant devait marcher, comment l'enfant devait faire.
Now imagine seeing your child every day with this awful large tumor that's growing with them and not be able to do anything about it. That's a level of pain I still cannot comprehend.
Tout le monde n'était pas, mais on ne pouvait pas pleurer là. On pouvait pas, on fallait qu'on la conseille, on la console seulement, on ne pouvait pas pleurer là où elle était. Ça c'était quelque chose, mais c'est chargé. C'est que, mais c'est chargé comme venir voir au bateau.
It's never an easy surgery, so all-day procedure. It's close to 8 or 9 hours. But he did well.
Quand le docteur est sorti de la salle d'opération, venu me rendre simplement, ça s'est bien passé. Ils sont venus nous prendre, nous sommes partis voir l'enfant. J'ai touché la carte. J'ai dit, bon, ça va. Dieu au contrôle vraiment. À tous les docteurs, tous les médecins qui m'ont soutenu pendant l'opération. Parce qu'eux-mêmes voyaient comment moi je faisais. Ils avaient pitié. Et me consolait, non, ça va aller.
Patients never stepped out of a small village or a small town in Cameroon. Coming to a ship full of strangers, hearing different languages spoken. Yes, it's an intimidating experience, but that they come because they have hope and they see the love that is really love in action, not just spoken about.
Quand lui va grandir, on va demander les photos. Et Dieu aussi merci à notre chef, tout ce qu'il a fait pour moi. Je lui disais encore merci parce que le Seigneur ne nous a pas abandonnés. Le Seigneur s'est souvenu de nous.
So I just wanted to play this because these are the stories that we actually live by. You know, we look at a lot of statistics, but once you are in those scenarios and you see family after family, and you know, when I think about actually where my own journey started, it really started with my parents. This is a picture of my parents on their wedding day, and they were both physicians, and they were educated in Egypt. And at that time, you had to go and spend several years in essentially the villages where many of the places they went to, they were the first physicians or the only physicians. And so this is sort of the environment I grew up in. And 3 years later, my brother came. And my brother was cyanotic. And at that time, all they could do is, you know, there were no echocardiograms, there were no MRIs, there were no pediatric cardiac surgeons in Egypt available. And really all they could do is diagnose him clinically with probably what was a tetralogy of Fallot. And my parents, you know, did their best to get him care, but he passed away at a few months of age. And that, you know, when I think about why I went into pediatric surgery and why I go to places where this is still happening, there's very little doubt in my mind that this is really was the impetus for me. And in fact, you all have applied to medical school, and you know, you all have to write essays when you apply. And when I applied to pediatric surgery residency, this was the very first paragraph. I said the baby was born to two young physicians beginning their practice in rural Egypt. Shortly after birth, he was noticed to be cyanotic and was presumptively diagnosed with tetralogy of Fallot. No help was available, and the baby died after several months. That baby was my little brother. And that story is still repeated, you know, every day, thousands of times around the world. And that's really the reality. So when we look at these statistics, we have to think of what the human cost really looks like. And that's the human cost. So I have to say, like, this is a lesson I never forgot. Because, and I remind this, you know, remind my trainees of this, remind my students of this, certainly when people accompany me in my missions, that it's always very difficult to see your child suffer. We all know that. Some of you may have your own children. But the only thing more difficult than to see your child suffer is to see your child suffer and not be able to do anything about it, not be able to provide them any help. And that is the reality for millions of people who see their children suffering. So my parents then, when I was 6, left and went to work in Nigeria for a long time. And again, we were in very small towns. Ilorin was one of the smaller capitals of the states in Nigeria. And that experience really had a tremendous impact on me as a young boy for 2 reasons. Number one, I really got to understand what it's like to grow in a multicultural environment with people of different colors, different faith, but still be able to form a community. And these are the building blocks we need when we are thinking of going to other nations and doing work there. But the other thing was that to use what you have, and I love this picture. I mean, it wasn't intended when it was taken when I was 6, but it really depicts a lot because like every 6-year-old boy, I wanted a bike. And in the town where we were, there was no bike shop. So my parents found somebody who wanted to get rid of this big bike. And they said, that's all you have. And there were 2 problems. I was too short to reach the 2 pedals at the same time. So I had to throw one pedal and try to retrieve it with my other foot. And I couldn't stop because if I stopped, it meant that I was going to fall. So I had to keep pedaling until I find a tree or something close and I could just slow down and leave. So it made for a lot of scratches, a lot of injuries, but I was able to bike. And that was really kind of depicting a lot of what was done back then. And still what is done now is to use what you have. You may not have everything you need, but you can always use what you have to provide services. And this is really how I grew up. My father was an orthopedic surgeon. And, in Nigeria, he was also a general surgeon. He was an obstetrician. I mean, he did basically any surgery that needed to be done. And when we went back to Egypt and he started practicing only orthopedics, I remember very well going with him to the hardware store because a lot of times he couldn't find the nails and the pieces that needed to be used for the operations. And he would take the pictures and go to the hardware store and find what was the closest thing he could use, and he would sterilize it. And that was the instruments that were available. So fast forward 25 years, I, sort of lived with this growing up. And then I do my undergraduate degree in Michigan, come here to McGill for medical school, go back to the States to do my residency. And my first year of practice, I take time off and I go back to Africa. And I split my time over a month between one of our mission hospitals, which is in Nairobi, and AMREF. Some of you may have read about AMREF, but it's essentially an organization that really provided care to the remotest parts of Africa in a very unique model of cooperating with the regional hospitals. It was quite an eye-opener in terms of how even in the most remote of locations, you can actually bring good care. To my right, this gentleman is Tom Rossen. He was a Dutch surgeon who worked with AMREF. And the way it would work is they would be in contact with a regional hospital, and the hospital would sort of pile up a number of cases that need to be done. And then Tom and his crew would bring, the capable surgeons and all the equipment they need and land literally in a cow pasture. I mean, there are no airports or anything like that. And run a clinic and then operate for a week and provide the surgical care that's necessary. And the follow-up would be done by the local physician, who is the gentleman to my left here with his wife. And the one thing that was quite amazing, 25 years after I had lived in these settings, this was in Maasai land in Tanzania, is that time had stood still. It's like no time had passed. That 25 years, almost like it was a moment. In other words, it was exactly as I remembered the hospitals where my parents practiced. You can see here what the sterilization was like. Essentially, all the instruments were being boiled in hot water. And there was one autoclave for drapes and other cloth material and so on. And that was pretty much it. There really wasn't a whole lot to do. For anesthesia, all that was available is ketamine, ether, paralytics, Demerol, and endotracheal tubes, but none of the other agents were available. And we're talking about the turn of the century here. This is not, 50, 60 years ago. And there are places still in Africa that actually are still running, as you see here, with those types of resources, believe it or not. The anesthesia monitoring was, as you see here, they had never seen a pulse oximeter. There were no cardiac monitors. The anesthetists were incredibly skilled. The anesthetist's eyes were on the child's lips, looking at the color to make sure that child was oxygenating well. Her assistant was bagging the patient, and her left hand was on the temporal artery pulse, and that was the cardiac monitor. And we did 27 operations like that with no morbidities and no complications, which was really quite amazing. But the lesson I learned is, do you need certain equipment? So while we had this amazing shortage of really necessary equipment in the operating room, there was an ultrasound machine that had been sitting collecting dust for 2 years, and somebody just sort of donated it. And I've since seen this in Africa over and over and over, of things just being donated that have nobody to use them, nobody to service them, and they really come to waste while very necessary equipment is absent. In this case, I was able to use the ultrasound to make some diagnosis, but it was an instrument that really had not been of any use. And of course, I'm not going to show you, tons of pictures of patients, because that's really not the point. But the rule was late presentations. And this was one of the saddest cases I've had to do, a forearm amputation, the only one I've ever had to do in my career, right? A gentleman who had an eroding squamous cell carcinoma that had completely destroyed the hand and the forearm and the joint. And patient after patient after patient had these late presentations just because there was no care to be had. But the wonderful thing, and probably the best lesson from that early experience, was how we can all work as a community. The model of sort of the expatriate surgeons who come in and do stuff and leave, and really wasn't the case. The work was teamwork. The African teams were well integrated with the visiting teams. We ate together, we had breakfast together, we spent the evening together, we planned together. And it really was a lesson very early on that is the model we have to follow, not the sort of colonialist or neo-colonialist model of people just coming to do things and leaving. And then I went to our mission hospital, and my desire was to introduce laparoscopic surgery. Again, this is in 1999. And there was only one hospital in Nairobi at the time. So again, laparoscopic surgery was already very well developed around the world. But in Nairobi, only the Aga Khan Hospital was doing laparoscopic surgery. It was like the hospital for the rich. So only those who could afford it were able to get this. And I really felt that this was not right. So you can see the ad that went into the paper there on the left. And we had, people lining up and kidney stones and all kinds of things that were really not amenable to laparoscopy. But people were just seeking hope. But we identified a number of patients who needed laparoscopic cholecystectomies, laparoscopic splenectomies, and so on. And again, it was something that really was implanted in me early on, is that, you don't settle. We always have to provide the best care we can offer. Now, sometimes the best care we can offer is not the standard of care. It's not what can be offered in the West. But if we can, we should. We shouldn't exclude patients just because they happen to be living in Africa or somewhere else. And it was really amazing to see this, what I call the Lab Chole graduate class, the first patients to undergo laparoscopic cholecystectomies, and really the amazing feeling they had that they could actually get back to work and serve their families. And the notion in Africa of having surgery and then being out for 6-7 weeks suddenly was defeated. And at the same time, teaching surgeons there and really going through the process of how to develop skills and so on.
Yes.
And I continued to go back there in my first few years when I was in California. After I finished my pediatric surgery fellowship here in McGill, I went back to California to practice. And you can see I was spending most of the time in Kenya, Tanzania, and Zambia. And you can see, the amazing gap that existed in terms of what the financial healthcare resources were like. And on top of that, this was when the HIV epidemic was absolutely raging. And this ad on one of the windows of the hospital really depicts the absolute disaster that was occurring in Africa with HIV. The estimate was that in Zambia, it was almost 1 out of every 5 patients was infected, and the life expectancy had fallen before under 40 years. The president of Tanzania had declared it a national disaster. And in Kenya, AIDS deaths had doubled over 6 years. So AIDS and HIV was ravaging Africa, and combined with the fact that the human resources were very, very, very scant. So it was just a perfect storm of an amazing need, something that still didn't have effective treatment, and very poor medical resources. And I really saw, we've been talking about how COVID has stretched our resources, but if you had been there at the time, this was nothing. I mean, this is what we went through was absolutely nothing compared to the HIV epidemic that raged in Africa at the time. So as I said, I continued to go back and see patients, and I established a relationship where the hospital would screen patients before, would have patients ready, and then would go in, and I would spend a few weeks, and then there would be follow-up by the local surgeons afterwards. So it was really a setup where we knew we were providing the care that needed to be done, not just surgical care, but preoperative, post-operative. But in 2005, there was an event that left really an indelible impression on me that has never, ever left me. And I still remember this girl and the incidents that happened as if it was yesterday. I had just landed with my wife in Nairobi, and it was Easter Day in 2005. And the surgeon who was my host dropped us off at the hospital, and then said, before you just, take your bags into your apartment, and I have to take you straight to Kenyatta Hospital, which is their big national hospital in Nairobi, 3,000 beds. It's really the big referral hospital. And I said, well, we can go tomorrow. And he said, no, we're going now. We have to go now to see this patient. So we go to Kenyatta, and we go to the pediatric ward, and we see this little girl. And you can't even see her face because her face is being hidden by her abdomen. But here she is. Here's her abdomen, and she had been sitting in the hospital for 8 months with no surgical intervention because the mother couldn't pay the bill. And the tumor had gotten so large that it was already eroding through her abdominal wall. And I really, I had already been in practice for many years, and I just did not think that something like that can still happen in the world we live in today. So we were able to pay her bill, take her to our mission hospital. We removed the tumor. The tumor weighed as much as she did. And this has been another lesson to me. The resilience of children in Africa has just been humbling. It has been absolutely amazing to see what they're able to withstand and still survive. And when we operated on Isabella, we knew that the chances that she would survive long-term are low. She didn't have adequate chemotherapy to treat the tumor adequately, although she did get some, and we tried to, to create a treatment plan for her. And she actually did very, very well post-op, and we were very happy. But a year later, she came back with lung metastasis and died. And this was not a surprise to us. We weren't really operating to save her. We were operating to save her dignity. And that notion I said earlier, and I'll probably mention several times, of just a mother seeing her child for 8 months eroding and not being able to do anything about it. And Isabella left an indelible impact on me because she was really a poster child for the plight of Africa's children. Inadequate facilities, inadequate diagnostic modalities, inadequate therapeutic resources, few pediatric surgeons, and many of the pediatric surgeons work in private practice. They have to survive. They have families to feed. So the fees have to be paid, and there's really no true public health system, and therefore patients suffer. And unless you can pay the cost of treatment, you really get no treatment. But I'd like to feel like she did leave a legacy. So we realized that, there were surgeons in Kenya who could have actually treated her. And the hurdle was the funds. So with some of the surgeons there, we created Surgical Hope Children's Fund. And the idea was just to find patients who are good surgical candidates and make sure they are funded to be treated there instead of being flown out or wait for a surgeon to come in to get the treatment they need. And this has been very, very successful over the last 15 years. But the other thing that really moved me is I thought, okay, you know, we need to bring those surgeons who are working in those settings, and we need to hear their stories in our world, in the West. And in this picture here is a meeting of the Pacific Association of Pediatric Surgeons just a few months after Isabella's story. And you see Dr. Stephen Bickler, which these are names you may have heard about, who are very prominent in global surgery, George Azzi, and other surgeons from throughout the world. And in the middle is Dr. Safwat Andraus, who's an Egyptian Kenyan who had really dedicated his life to try to take care of these children. And it was the first time that we actually bring someone and try to understand from them what life for a pediatric surgeon is really like on the ground in these societies. It also taught me what are the essential elements that we have to know about the region and its people. We have to understand the culture. We cannot just pop in and assume that we know what we're doing. We have to understand what the medical needs are. The countries are not all the same. The medical needs, even within different parts of the country, are different. And very important to avoid surgical adventures. You know, I had gone through medical school and residency, seeing surgeons come in and, you know, say, oh, I've spent 2 weeks, and they show pictures of 30 cases they've done, but nobody knows what the outcomes are. You know, they went and left without any partnership in the local country. And this is really, this finally has risen to the surface as you know, being unethical. So context in the host country, ways, a system that is going to follow these patients and be able to communicate with you if they continue to have problems and so on. Of course, necessary licenses and equipment. But the main lesson was that I really strongly believed early on in my career in the value of this work. And I believed in it so much that I thought trainees need to understand this as part of their growing into medicine, as part of their training. So when I came here to McGill in late 2008, my very first project was to integrate an international rotation in Kenya into our pediatric surgery fellowship. And here you see a picture of Dr. Robert Beard in our hospital newsletter. He was the first fellow to go. And so we did a program where he would go and spend a month at Kijabi Hospital in Nairobi, which is in the Rift Valley. And we made sure that he is well supervised. We had a partner there. We had an actual defined program for what his training would look like. And when Rob came back, his first idea was, we need to make this an exchange. It's not just our fellows who should go, but we should receive their fellows. And within months, we did exactly that. And we started receiving their fellows. And our objectives was to really expose our fellows to pediatric surgical pathology that they will not see, to see what patient care looks like in a low resource setting, to understand the challenges that confront pediatric surgeons in those settings. And I call these pediatric surgeons the heroes of our profession, because they really do the best they can with very, very few resources. To understand that even in a low resource setting, whole person care is possible and is deliverable. And to appreciate the principles of evidence-based care to really still provide the best scientific care you can. So when Rob came back, within a few months, we had Dr. Farhoon Ayeli, who's an Ethiopian pediatric surgeon who was training at Kijabi in Kenya. And we continued with the program as an exchange program between our hospital. We were the only pediatric surgery program in North America to have this exchange. And after we had 5 fellows go and 5 fellows come, we did a study to understand their experiences. And the first thing we found is that it was really complementary. The training that the African fellows were getting in their home country was very different from the training that our fellows were getting, because there they had to know how to deal with hydrocephalus and with, you know, urologic conditions and orthopedic fractures and so on. And it was really complementary to have this exchange, because the 2 fellowships were not the same. And as far as the goals of the exchange program, it was clear that it was very beneficial to both our fellows and their fellows. So we continued this, and we actually fought to make this allowable. But at the time, the American Board of Surgery was not allowing this. So we were an outlier. And we actually published this editorial in late 2017 called Let Our Fellows Go, because the American Board of Surgery felt that these were adventures and the fellows should not go there. They're not going to learn much. And it really was almost disrespectful of the experiences in low-income countries. And so we really stayed on their back, kind of trying to shame them into changing their policy. And it took only about 5 years, but thankfully they did change. And actually starting this spring, all pediatric surgical fellows in North America are now allowed to go on these exchange programs in low resource settings. And then I continued when I came to McGill. There was a program with the CHU in Rwanda, the university hospital there. And my partner, one of my partners was going there quite regularly, so I joined him. And in Rwanda, again, this was really, the first time I realized how small our community is, and how, we may be practicing in different places and have very different environments, but really have a common goal. So in Rwanda, I met Edmund. Edmund was a surgeon here operating across from me. He was incredibly gifted. For a country of 12 million people, there was not a single pediatric surgeon, not one. There was a volunteer German surgeon who would do a little bit here and there, but there was no full-time pediatric trained surgeon. And Edmund and I really worked together day and night. People were very fit and very small there, so I was ambitious and I thought I could fit into small scrubs. And I got incarcerated into my scrubs, and he had to get a pair of scissors and free me up from my scrubs before I suffocate. So he actually saved my life. And we continued to collaborate. And it was really an example of how it's all about relationships. A lot of the work we do is about relationships. And this is an example of how a relationship begets a relationship. So again, this is back in Kigali in 2013. There's an anesthesiologist from Harvard, there's Edmund and I, and there's Robin Petrozzi, who was a surgical resident from the University of Virginia, doing her research there on trauma. And Edmund then joined the Kijabi program to become the first Rwandan to train in pediatric surgery. And then we hosted him, and we went apple picking with him in the fall with my daughter. Robin became our fellow, and then through the exchange, she went back to Kigali in Kenya to operate with Edmund. And when Robin finished our program, she went to University of Florida to become a surgeon there and decided to dedicate 3 months a year to work in Rwanda, on an ongoing basis. And she became really his partner. And then I'll speak about this in a minute. We were able to help them with capacity building through a book distribution program. And now there's a second, Jules, a second pediatric surgeon in Rwanda. What does this all mean? I mean, it's nice to have these relationships, but what do they translate into? Well, they translate into something like this. When I was in Rwanda, you may all be familiar with a condition called gastroschisis, where babies are born with their intestines, all exterior to their body. And when I was in Rwanda, not a single patient with gastroschisis had survived. The mortality rate was 100%. And when there's a mortality rate of 100%, there is an intimidating and a kind of take it for granted attitude that develops, is we cannot save these children. So we should not try because we're just wasting resources. So the time I was there, I worked very, very hard to save a child who actually had a reasonably good prognosis, gastroschisis. We were able to close him completely, get the bowel inside. And, I was ecstatic because I felt if I could just save one baby, it will remove that stigma of the disease, that this is not survivable. People realize that this is survivable. Let us try to help these babies. But unfortunately, this baby died. And I called my dispatch winning battles, but losing the war, because we did everything right. But because of the lack of expertise, he had a ventilatory accident and he succumbed. So when I left, there was still zero survival of gastroschisis in Rwanda. Now, through the work that Robin and Edmund have been doing together, they just published this paper very recently, and the survival rate is now 22%. They've had 21 patients survive. And that is phenomenal. It may seem like a very low rate because our survival here in Canada and the US is 90-some%. But when you go from 0 to 22%, you know that you're heading in the right direction. And when you see baby after baby leaving the hospital, the disease starts to lose its hold on the surgical community. So this is what these kinds of partnerships actually accomplish. And we did another study from our center looking at pediatric surgical capacity in Africa. And you can see the number of pediatric surgeons here, how low it is. There's a few spikes in Tunisia, Senegal, Egypt. But even in those countries, you'll see that most surgeons are practicing in the private sphere. So this is, again, I mean, in some of these countries, they're actually incredibly gifted. In fact, more than gifted, surgeons who contributed to the surgical science and have some of the best expertise in the world. But even there are still problems with access because the number of patients who can access the public system is still quite limited. And unless you can pay, oftentimes you still do not have the access you needed. One of our colleagues from Cairo University published a paper recently trying to see what happens to patients who are not accepted because of the lack of beds. And he found that a large number of those patients succumbed within a week, did not survive at all, and just could not get alternative care. But what was interesting is the perceived needs of those surgeons was not about, come and help us all the time. If you look at what their top needs are, a lot of them had to do with capacity building, with education. Education was huge, funding scholarships for clinical training, collaborations for trainee education, opportunities for overseas clinical training. And it really dawned on me that we can do a lot of global surgery without leaving my office here. We can be involved in global surgery without having to be halfway across the world. And so this prompted us to establish a fellowship in our department called the Jean-Martin Laberge Fellowship in Global Pediatric Surgery, named after my senior partner, who would also contribute a lot of his time to work abroad. And the idea was really to bring emerging surgeons to study academic pediatric surgery and be able to take that back into their countries and do cutting edge research that can actually potentially help change policy. So we've had several fellows. Not all the fellows have come from developing nations, but we've had several fellows, and two that are one has already completed their degree, Dr. Luc Malema from the Democratic Republic of the Congo, and Dr. Fabio Botelho, who's really an incredibly bright Brazilian surgeon who's just completing his PhD in the next year. And actually, Fabio just came back from Brazil where he did the very first trauma for kids course, the very first trick course in Brazil. He just conducted it. So it really does make a difference. Giving these tools does enable people to go back to their communities and make a huge difference. And we now have several fellows booked until around 2026. Another thing I've been very fortunate to be part of are the visiting scholars program. And that is in our meeting, like the Pacific Association, like the Canadian Association, we invite young surgeons from low-income countries to come. And it's not so much that attending the meeting, will have a huge impact on their career, but it's again about networking, about establishing relationships with these surgeons that then can go and bear more fruit. And in both the PAPS meeting and the Canadian Association of Pediatric Surgeons meeting, we invited many of these surgeons to come back and give us their feedback. And that's really the message that comes through, is that their connections with surgeons in high-income countries makes a huge difference. Sometimes it's just about running cases, getting advice, getting help with a case. Sometimes now we can do Zoom and we can connect with each other live and so on. And it really, the world has become so much smaller. But what is amazing is that this can also be life-saving. This is an article that was actually published very recently. And this is Dr. Dunya Mogul. So Dunya, I invited her to come to the PAPS meeting in New Zealand in 2019. And she is an amazingly bright, one of two female pediatric surgeons in Afghanistan at the time. And when the Taliban took over, her life was immediately in jeopardy. And she had to be going from house to house, not knowing if she's going to survive to the next day. And it was actually PAPS and their network that was allowed Dunya to escape from Afghanistan. And she's now here in Canada trying to restart her career. So these relationships, I cannot tell you how vital they can be sometimes. Now, when you're doing global surgery, it really becomes part of everything you think about. It's not like I'm going to do this as, 20% of my life. I'm going to go away and, teach or capacity build or operate. It really becomes a notion of everything you're doing can have a global surgical angle to it. And so I was very, very blessed in 2019. At the end of 2019, I was able to publish a book that I've been working on for a long time. And the entire time I was working on this for 4 years, I really wanted to think of how I can get this to the surgeons who would not normally buy this book. And it was really important for me to get it to them because the book was not about the science of pediatric surgery. It was not another book about, the pathophysiology and the radiology and all that. It was really about patient management. How do you actually make decisions when you're faced with a patient standing in front of you? So we looked at different models and we're able to get a foundation here in Montreal that funds my chair to create copies specifically for surgeons and LMICs that could be sent to them completely free of charge. Now, to be honest, in many of the countries, there are pirated copies that can be obtained, but we also wanted to discourage that because no surgeon does that sort of, feeling good about trying to get educational material that way. So I started this project, and then Dr. Mark Levitt, who is a very prominent pediatric colorectal surgeon in Washington, D.C., joined me a few weeks later, and he had 3 pediatric colorectal books. And so we got a grant from his foundation, and we started sending these books to surgeons all around the world in low and middle income countries. And the effect was really pretty amazing. I mean, we just started by wanting to sort of make sure they have the knowledge. But what happened is that it allowed us to build a community of pediatric surgeons from all around the world that could be in touch with each other, that could share knowledge, share experiences, share difficult cases. And it really created a tightly knit learning community with people from around the world, from countries that are so diverse and so different, where normally they would never have communicated with each others. And to date, we've been able to send this to 300 different institutions in 80 countries with thousands of trainees and pediatric surgeons benefiting from them. And this is the kind of partnership that it's created. I actually decided to put these two pictures just this morning because Dr. Mansour Nasirov is, again, bright and ambitious young pediatric surgeon from Uzbekistan. Same thing with Gabriel Anthony Villa. And now they join us actually every Wednesday. Were with us this morning. Since we meet by Zoom and do our teaching by Zoom, they actually join us for our morning meetings. And, the question is, why not? Why not? If we're doing something virtual, why do we have to still restrict it to our walls? Why not open it to people to bring their cases? And Mansour actually has presented cases in our meeting before. And the same thing with a group in South Africa. We've become very tightly knit. I participate in their teaching, participate with their residents, and really has allowed us to kind of think of education way past our borders and think of how we can learn together. I was just a few weeks ago in Ecuador, and it was just absolutely satisfying to see young trainees who have sort of been inspired by this let's all learn together approach, working together, sharing knowledge, sharing cases. And it's again, just been really a joy to connect with people through this program. And then we took the concept of the book of having an interactive learning process, and we put it on Twitter and on YouTube and on LinkedIn and on Facebook. And there's actually one that's been posted just yesterday. And what we do is we post a scenario and allow people to interact with the scenario. We used to do it twice a month. Now we do it once a month. And people will debate and will, give their judgment. And then we kind of pile all that up and we create a commentary. And again, the very amazing thing is that I'm now really trying to recruit surgeons from low and middle income countries, not to just be the consumers of the knowledge, but to be the providers of the knowledge. So the episode that was just posted yesterday was actually posted by Dr. Emiliana Lia, who is a pediatric surgeon in Bandung, Indonesia. And I'm not going to say what the case is because some people might still be trying to think about it. But it's really, again, bringing us together in a community where we are both learners and we are teachers. And it doesn't matter where you're from. You can be a learner or a teacher, regardless of where you're coming from. A lot of things in global surgery happen by serendipity. I call it sweet serendipity. When I was in Kigali, it was the 20th anniversary of the Rwandan genocide. And a reporter from the Globe and Mail was following my dispatches. I always send dispatches usually on my Facebook page or on the Royal College of Physicians in Canada Facebook page or on our hospital page. But I always try to share my experiences with people back home. And he was reading my dispatches and he said, can you write something about your experience as a surgeon at the 20th anniversary of the genocide? So I did. This was in April. Months went by, and a few months later in September, I got a call from Mercy Ships asking me if I wanted to be on the board because the chair had read this and thought that I might be interested in Mercy Ships. And I really had no idea what Mercy Ships is or what it does, which was bizarre because I thought I was quite involved in global surgery and I knew a lot of the organizations that were involved, but I didn't know about it. And I was really quite taken aback by what I learned. And I'm going to just play this video for you because it's going to save me many, many slides. It's just 4 minutes and it'll tell you a little bit about Mercy Ships.
Almost 40 years ago, I took my first trip from Lausanne, Switzerland by train to Italy to look at ships. I listed some of the things that I didn't know or that I'd heard. Things like, you can't do that. It's way too expensive. I didn't know where we would find a crew. In fact, I didn't know what I didn't know. I was 32. That's awfully young. Almost 40 years ago, God took a huge risk. I could say that it all started with a hurricane or reading a book about the famous SS Hope. I could say it started with meeting Mother Teresa or with the birth of our special needs son, John Paul. Or I could say it began with my parents' simple way with grace and mercy and dignity with their small town helping hands. I could say all of those things about the very beginning of the idea that became Mercy Ships, and they'd all be true.
Mercy Ships is a unique organization because it is bringing services to countries that would otherwise never be able to access this.
The millions of people who either physically or financially do not have access to healthcare are staggering.
You just see people that need help. You realize that they have no way of getting help. And I want them to know that they're loved.
After the rejection and ridicule and hard lives that they've had up until this point, and to have a ward full of nurses and the other ship staff, people just pour out so much love on them. Love does make a difference.
People say to me, well, there's all these millions. How do you think you can change that? And you can change the individual one life at a time.
Bringing this hospital ship in, it's a state-of-the-art platform. Surgeons, nurses, professionals from all over the world, offering this free of charge at the highest standards is unique.
If you talk to any of the government leaders, as I have, they will tell you how beneficial Mercy Ships has been, not only for their people, but also in terms of a lasting impact.
We're working hard here to leave a legacy of improved healthcare.
Mercy Ships is particularly good at providing not just training, but training with an imbued sense of needing to pass on the training.
We can work together and do things together that we can never do by ourselves.
I have to say, of all the things I've done in global surgery, this has really changed my life. It's been an amazing experience for the last 6 years that I've been involved. This is Don Stevens, whom I met on my first trip in Madagascar, and this is his book. And it's just an absolute inspiration to see how a small dream can mushroom into such a humongous effort. And in fact, it's really no longer a dream because, we've been working with this ship you see on the left, which is the Africa Mercy. And for the first time in the car earlier this year when I was there, the two ships were both in the port. And this is the new ship you see on the right, which is the Global Mercy, which was actually built as a hospital ship with simulation labs, 6 operating rooms, essentially a floating hospital and medical school. And what is the mission statement of Mercy Ships? Following the 2,000-year-old model of Jesus, Mercy Ships brings hope and healing to the world's forgotten poor. They treat everyone regardless of their beliefs or their faith, and they allow anyone who wants to volunteer regardless of their beliefs and their faith. It's really a truly inclusive organization. It runs out of 18 countries, including Canada. The Canadian contingent, even though Canada is one of the smaller countries involved, they've actually are often the 3rd largest supplier of volunteers. You see here some kids, and you see some kids because there are people who live on the ship constantly. There's a school on the ship, and there are volunteers who are on the ship full time. And there are some volunteers who have been there for years. In fact, Dr. Parker, whom you saw in the video, is just finishing 30 years living on the African Mercy. Now, if we think about what are the limits of global surgery and what do we often kind of agonize about? We're working with poor resources, inadequate follow-up, the whole idea of colonialism and adventurism, people going to do things without really adequate follow-up, without accountability, and not really contributing much to capacity building, and then not having interactions with the local medical community. And I call Mercy Ships a unique global surgery model because it literally it targets all of these issues. For example, the ship is currently in Senegal, but the next country is going to be Sierra Leone, and they don't go in for 2 weeks or 4 weeks. Once they go into a country, they stay for 10 months. So they really integrate themselves into the healthcare system of the country. And in Sierra Leone now, there's already a forward operating team of a couple dozen people who are working with the local practitioners to figure out how the ship can best serve when it actually gets there. So that starts a year in advance, really integrates into a country's healthcare system, creates strong partnerships, gets guarantees for follow-up. For example, a lot of thyroid surgery is done for huge thyroid goiters, and they sign contracts with the host government to make sure that those patients are going to be supplied with thyroid hormones so that they don't become hypothyroid after surgery, and many examples like that. The ship has the same resources we use here in our operating rooms. All the technology that we have is available. All the imaging that we have is available. We don't have an MRI, but we have scans, we have ultrasounds. Very strong quality assurance model. I actually just get an email today to participate in the next morbidity mortality round on the ship. We do it now by Zoom wherever we are in the world. Excellent continuity of care because the ship is there for a long time, and partnerships are created with local physicians. And as you saw from the video, while the ship is there, tremendous amount of capacity building, renovating medical facilities, courses, you name it, from neonatal resuscitation to operative checklist courses for nurses, for anesthesia technicians, for surgeons. I always work with surgeons from the local country every time I go. And this is the meeting that happens before we start on every Monday. And one of the OR supervisors once told me, the idea of Mercy Ships can never work on paper. It only happens in real life. And that is so true. I mean, many of you have been in operating rooms, and you know what happens in an operating room when you get 2 or 3 new nurses and maybe somebody just left. Well, imagine an operating room where about 30% of all the staff change every single week. Just imagine that, and how it can still operate. And yet it's the smoothest, most efficient operating room I've worked in, with absolutely amazing outcomes. So it really is a one-of-a-kind organization. And this is what allows us to do these very, very challenging cases, and they're done in a very responsible way. For example, because sacrococcaleal teratomas had not been resected before I started to volunteer, in 2016, the cases had to go through a board to make sure that we're doing the right thing, that we're not leaving the child with a disability. And I'm going to show you this 2-minute video because it talks about another child with sacrococcygeal teratoma, but a little more from the crew side of it than from the patient side of it.
The way this came about is, I had been in contact with screening, sending me patient scenarios and pictures, and they said, look at this baby, see if it's something that you'd be willing to do. And I clicked and opened the file, and I literally stepped back. So teratoma is a Greek word for monster, and if you look at the baby's pictures, you'll understand why, because it looked like she's carrying a monster on her back. It's essentially a stem cell tumor. It's a tumor that comes from very early cells that develop the baby still inside the mom. And the one thing that made me step back isn't just that it was huge. I was amazed how this baby was born. The fact that her mom didn't die during the childbirth, the fact that the tumor didn't rupture or hemorrhage during the childbirth, that she didn't get stuck in the birth. I mean, I said, I cannot explain this. She looked like a beautiful, healthy, chubby baby. She still was carrying something that was eventually going to kill her. So the decision was made to proceed, and we proceeded slowly and just very deliberately. And 3 hours or so later, it was out. It was out completely. The other reason it's impacted me so much is how I've seen the care then after the surgery. I mean, this is a very, very difficult patient to take care of. And it was just a testament to the incredible amount of care and compassion the nurses showed this family, as they show every family. It just speaks tons to the miracles that happen here.
So that's the environment we work in. And if you want to learn a bit more about this, you can just Google dispatches from the Africa Mercy. You'll see a lot of the accounts I've sent. I've been on 6 missions so far in these countries with 4 trainees. In Senegal, of course, is when the COVID epidemic hit. So we had to interrupt our work there, but we went back and actually were able to find the patients that were not operated and were still able to provide them the care. And it's been and this I think relevant to you all, it's really been a huge part of my experience and a very important part of my experience to bring our trainees. And why do I feel it's important? Well, yes, they see some unusual pathology, but it's really not about that. None of the trainees have come back and said, wow, I had such a unique surgical experience. It's really about the human experience they see. And in one of my dispatches that I posted with the Royal College a couple of years back, I'll just read you what I wrote. I said, many trainees come to the Africa Mercy with their attending staff. The experience cannot be duplicated in our training environment. They will see late presentations of disease. They will understand the effect of poverty, abject poverty on health and life. They will learn to manage fragile patients. They will have to make difficult decisions. They will have to function well outside their comfort zone. But most importantly, they will see altruism, not just lectured and spoken about, but lived every moment of every day. They will experience the healing power of common purpose and common vision, not just to patients, but also to us who take care of them. So the motto we have in our field is when you save a child, you don't just save a life, you save a lifetime. There's a corollary to that that's very humbling. When you injure a child, you don't just injure a life. You injure a lifetime. And that's really kind of the constitution by which we decide what to do. Our vision for growth in pediatric surgical disease, now that we have 2 ships, is that we deal with curable conditions where there's a low likelihood of delayed complications, low likelihood of long-term disability, and low need for ongoing resource-rich care, treatable using the ship's resources, and treatable during the ship's stay in the country. And those are the criteria we use. But we are hoping to see more pediatric surgeons. So I was the first pediatric surgeon to volunteer in 2016. And we're hoping to do things like imperfect anus surgery, where we can actually stage it because different surgeons are going at different times, and continue with training and research opportunity. It's been really wonderful to see the growth in pediatric surgery. We went from 1 surgeon to 22 surgeons. There now have been 9 alumni surgeons who have participated, who have operated on the ship in the last several years. They come from 8 countries. And one of the most exciting things for me is that we are now seeing volunteer surgeons sign up from low and middle income countries, Egypt, India, and Brazil. And this is really, really exciting because we hope to empower surgeons to actually come in as teachers, as staff surgeons, not as mentorees only. But it has really been, again, a wonderful way to partner. There's usually about 40 nationalities on the ship at any one point, especially people from the host country. And it's just really a very unique environment. This is the surgery of Emmanuel, whom you saw in the first video. And again, just to show you how small the community is, this is Dr. George Knock. George is a Cameroonian pediatric surgeon, one of very few, who again trained in Kijabi, who came to our exchange program, who worked with me here. And then I got a chance to be back in Cameroon working with him and really continuing our partnership. In Senegal in 2020, we did a different model. So instead of just working on the ship, I actually spent 2 weeks as a host, as a visitor with the Senegalese Society of Pediatric Surgeons. We put on a workshop. We operated with them at their own hospital. And then they were supposed to send people to operate with us on the ship, but we had to interrupt the mission because of COVID. But we kept our relationship. And we went back in 2020. In 2022, one of the residents, Dr. Mansour Dian, you see here, came and spent the time with us. This is Fabio, our global surgery research fellow, and I, and Mansour spent the 2 weeks with us there. So it's really been an example of how we can all learn together and really follow the African proverb: if you want to go fast, go alone. If you want to go far, go together. And I'll just end by encouraging you all to sort of think past what we call this false dichotomy of fishing. You know, this Dr. Mark Schreim, I'm sure some of you who are interested in global surgery know him well. He's one of the most prominent global surgeons. He is now the Chief International Medical Officer for Mercy Ships. And Mark just wrote a beautiful piece, because this whole fishing thing is, you know the proverb, like, give somebody a fish, they'll eat for a day, teach somebody to fish, they'll eat for a lifetime. And I think it's easy to say that, but when you deal with some of these families that we see day in and day out, it's very hard to tell them, wait 20, 30 years until your infrastructure gets to the point where you can actually have the care you need. So they're not mutually exclusive. We can go and we can take care of one child at a time. And there's a lot of cynicism, and this happens every time I come back. Somebody says, okay, so how many cases did you do? It's not about that. I could do 20 or 30 or 40, but to those patients who had the surgery, who may never, ever have had it, who were cured of tumors, it's the entire world for them. And in fact, every time I go, my feeling is there's usually 1 or 2 patients among the 30 or 40 I operate that I say, if I went all the way just for that one patient, I'm happy. I wouldn't have had to do, another 20 or 30 patients. And that's really the attitude by which we can do both. We can teach people to fish by creating infrastructure, providing education, doing all the things I talked about, but we can also provide them with the care they need at the time they need it. So I'll just finish by kind of a personal message, I guess, because I know we have a lot of students here. And I think all of us in medicine, whether we know it or not, we have a quest for significance. We went into this field because we want to make a difference. We want to make a difference to others. We want to make a difference to the most vulnerable. And the 2 things that guide me is this verse from scripture: from whom much has been given, much will be expected. And to us who live in Western nations and enjoy all the benefits of our societies, we have been given so much, and much will be expected from us. And finally, the statement by Winston Churchill: we make a living by what we get, but we make a life by what we give. So I just want to thank my wife and kids, because they bear a lot of the burden of me being involved in these things, whether I'm away or not. They've been with me on a couple of these missions. These are my daughters when they were young, back in Guinea. And I also want to thank a lot of the organizations that have supported my work these last many, many years. So thank you. I'm sorry I took a little bit more time, Cecilia, than I thought, but I will stop here, and I'll be more than happy to not just answer questions, but hear people's thoughts and really anything you'd like to share. Fabio is with us. So Fabio is, I talked about Fabio in the presentation. He's a new dad. He has little boy. And congratulations again, Fabio, from people around the world. And Fabio just came back from Brazil 2 days ago, where he really, participated in some very, very, very significant capacity building and changing the outlook for trauma patients. So go ahead, Fabio.
Well, actually, I don't have nothing to say. Hello, everyone. Beautiful talk. Dr. Me, every time that I saw, like, actually, I see one of your presentations, I get inspired again. So, and every time is different. So you keep motivating us. And I really think that, as you mentioned at the end, sometimes if you do just for one patient, for me, it's already, I will be fulfilled for that. So, and I think that most important maybe here is to show the other aspects of, like, as a surgeon, like that you can have different roles, not only in the operating room. So through education, through like missions, through advocacy. And I think that only after I did that I was not a surgeon only in the operating room, but also like during my life, and like advocating for like better quality of care. That was the time that I really felt fulfilled. So I think that it really helped me to expand my view and like not to limit our profession. So that would be my 2 cents. Thank you very much.
Thanks, Fabio. I'm just looking at the chat to see if there are any questions, but they're mostly comments in the chat. There are a number of surgeons here from this global community that I described, and I just want to thank them all, because I know for them also the time is a very difficult time in some of their time zones. Any other questions, comments? I'm again more than happy to address anything. Let me just see any involvement opportunities for pre-med students. I would love to contribute in any way that I can. Okay, well, Stephanie, let me tell you a story, because I love to answer questions. It's not going to be a very long story, but on my very first trip, when I arrived, I had lost my luggage. It was a horrible trip. I got there like through a different route, different flights. And anyway, and I arrived on a Friday, and when you arrive, you have to go through security, like to understand what to do if there's an emergency on the ship and so on. So there was this young lady, and she said she was a student at Ohio State University in undergrad, and she had like a purser's outfit on, So I thought, oh, it's pretty cool. Like, take a year off university, and, you're kind of in the captain's, you're volunteering in the captain's office and the purser's office. And then, so that was a Friday. Saturday, I was going to the cafeteria, and I saw her on her knees sweeping the floor. And I said, hey, what's going on? Did something spill? Do you need help? She's like, no, I'm actually volunteering to be a janitor. I was just substituting for somebody else yesterday. So she was a university student actually volunteering on the African Mercy as a janitor for a year. Not that you should do that, but the point is, yes, there's all kinds of opportunities for all people. It's a community. It's not a hospital. I mean, it's a hospital. It has nurses and physicians, but it also has electricians. It has plumbers. It has IT people. It has people who run the cafeteria to feed 1,000 people every lunch and dinner. So it's a whole community. And so if you go on mercyships.com.org or mercyships.ca, you will see all the types of volunteer opportunities that are available. You don't have to be already a physician to do it. Right. So Gabe, I think so Dr. Villa is a pediatric surgeon in the Philippines, and we would love to have you, Gabriel. All you'd have to do is just email me. I'll link you up with the recruiters, and we can definitely get you signed up. Cecilia, I'll leave it up to you.
Yes, well, thank you, Dr. Emil. I think everybody appreciated this talk, very inspiring and eye-opening. So thank you so much for giving us this opportunity to learn from you and your experiences. And I don't know if there are any other questions.
I see one from Prashi here. Go ahead, Prashi.
Hi, Dr. Emil. Thank you so much for your talk. It's always inspirational hearing you talk. The one question that we got in the registration form is from the students, like how the students who are in the first year or second year can get involved in the global surgery or global health work more in the meaningful way, and like what kind of skills they can develop which can help them in the future. So if you can like just share some thoughts.
Yeah. So, I mean, I would really strongly suggest that you consider, if you have not been, hadn't grown up in that environment and it's something new to you, to consider doing an elective in a low resource setting. And, there are databases that students are familiar with, and there are many organizations that can help you. There is a global initiative for children's surgery if you're interested in the pediatric field, but you may be interested in any other medical field. And I think that's kind of a safe way to do it, because it is giving you exposure without really committing you to having to do something that you may not be comfortable with. So that is always a very good first start. There are a lot of students in the first year or two who go on short-term missions in many different countries as support staff. You may not be carrying a stethoscope and doing the physical exam as a first or second year student, but you're doing logistics. But it's important because, just like happens on Mercy ships, those logistics is what makes the work happen, is what makes the mission work. If people were not doing logistics, it would not happen. So that's another way to get exposure, before you get to the point where you really have the clinical skills to be able to offer yourself as a physician. And and just to be perfectly honest, some people do that and realize, it's really not for me. I don't feel I'm comfortable in these kinds of environments. I mean, they can be harsh. These environments can be really harsh. So, and then some people are from our fellows who go, we've had 7 fellows now go to Kajabi. And I can tell you that the overwhelming majority have actually continued to do some type of global surgery work. So it's kind of plants a seed, but others have decided, okay, I'm happy I got the exposure, but I don't think I'm ever going back, But it's the exposure that will tell you. So that is a way to participate early without sort of committing yourself to be in an uncomfortable situation. We have Per, you have a question from Barcelona. Unmute yourself. You're still muted.
Yeah, do you hear me now?
Yes, go ahead.
Okay, well, hi everybody. First of all, thank you for presentation. It was really inspiring, and also with a lot of hope. In your message, in all your presentation, it was amazing. Thank you for you. So my question is, how on the surgical and the human experience you get in all your travels, Nairobi, on the Mercy ship, Cameroon, Senegal, is helping you and also your team nowadays in your daily surgeries at Montreal?
Excellent question. Excellent question, because I think we can easily get into this kind of framework or mentality that we are going there to provide innovation and to provide care. And I can tell you that I learned a tremendous amount from my experiences there. First of all, I learned to appreciate what I have, okay? And to really be thankful for what we have, because we tend to take what we have for granted, okay? But, I am really big, and, Fabio knows this very well, others who work with me clinically, I am really big on, preservation of resources. Like if I'm in the operating room, I don't like to open another stitch if I don't have to. I mean, it's kind of like becomes a little bit obsessive almost, but it's really my time away that teaches me to do that. Don't do a test that you do not need. Educate people about the value of preserving resources. And unfortunately in North America, much more in the US, but now becoming very prevalent in Canada, we're very resource oriented. We want to do tests, we want to do things, we want to buy stuff. And I'm usually the one kind of pushing back against that. And I think my experience in Africa, honestly, has a whole lot to do with that. But the other thing is that, and this addresses the point I made a little bit earlier, is that, yes, we can also give a very pessimistic presentation and say, look at the horrible things that are happening in these numbers. Well, if you think about it, I mean, what do we as physicians do wherever we are? We're trying to advocate for one patient at a time. I mean, I spent, I'm American, I spent most of my career in California training and practicing, and I would see patients who were presenting late, who didn't have insurance, whose parents were working, but they didn't have access to the system, and, trying to get them care. And yeah, I can't fix the whole system. I can't get insurance for everybody who's uninsured, but the patient who's across from me now, I can try to help them. Happens here in Canada. We're in a crisis right now. Our hospital doesn't have beds. I have a patient with a recurrent ovarian tumor. She needs to be operated, having a hard time getting her a bed. I can't advocate for all the patients who need beds, but I'm going to advocate for mine. So that's the approach, really, again, we learn in low resource settings. Yeah, I cannot change. I'm not going to change all of Africa. A lot of it hasn't changed since I was a child. But those who come across my way, I will try to help them. And it's really the same notion, whether we're in Senegal or in Guinea or in Canada or in Los Angeles. I mean, it doesn't really change that much. That's really our incentive to do what we're doing, right? So that is it's just every time I spend time there and come back, it just empowers that idea in me. Clara? Barcelona, we have a good Barcelona contingent, it looks like.
Good night here in Barcelona. Thank you very much for the lecture. It was very inspiring. And my question was, every college teaches like the surgical techniques based on his own country resources. So I was wondering, if you volunteer in another country, how do you face doing that exam procedure, but with such low resources? How do you face that without no previous formation, with your own formation, which is with greater resources?
So that is tough. In fact, Fabio and I, we were together a couple of months ago, and we had many patients with undescended testes, and these are older children, which normally they would come to our care younger here. But when it's a palpable one, then the surgery is the same, But when it's non-palpable, we try to do a laparoscopy. So there we didn't have laparoscopy, and it's done two things. First of all, we have to, sometimes we mail other surgeons and look at other techniques by which we can explore and so on. And that's what we did. We kind of, acclimated to the environment. But it also made me advocate for having laparoscopy on the new ship, because we have a new facility built as a hospital ship. And I really started pushing hard for having laparoscopy. And again, I mean, I did this 20 some years ago in Kenya when they thought, oh, just do everything open, you don't need laparoscopy. No, we do need it, and we should provide it, because that is a standard of care. And just because we're operating in Africa or in Brazil or anywhere else doesn't mean we should still not. Now, if it's absolutely prohibitive, so be it, but we should at least try. So we should really try to bring their standards to our standards in terms of what is best for the patient, because sometimes what's best for the patient there is not what's best for the patient here. Okay. But the other thing is that, yes, you're right. We do have to sometimes adapt our procedures to do, different procedures that we may not be doing here so much.
Great. Thank you so much, Dr. Emil. I don't think there's any more questions. Just before we finish this talk, I would like to take a screenshot, like a picture. So if you feel comfortable to open your camera, we could take a quick screenshot of this event.
I think a lot of people are in their pajamas.
Yeah, it's getting late. Okay, so I'm going for it. Smile. Perfect. Thank you so much. So thanks everyone for attending this conference. I know it's late for some of you, so thank you again very much.